If you could diagnose the state of male health in 2025 in one sentence, what would it be? And what do you think is driving it?
In one sentence, male health is, that I could probably even do one word. I would say male health is 2 words. Not taken care of. I guess that's 3 words. Anyways, yeah, male health is not being taken care of. I did a podcast on this called The One Main Thing That's Harming Men's Health. And this one thing is that the males will take this role that I call the sacrificial male. They feel like they're doing a good thing for themselves or their family by working so hard and ignoring that little twinge in the chest, ignoring the joint pains, ignoring these issues that are going to come up and give them less health span and less quality of life and less quantity of life. So ignoring their health that's the average male. Of course, there's biohackers. There's people on both ends of the spectrum. The answer is always, it depends for everything. But that's where male health is.
And do you think this sacrificial instinct that male have to ignore the pains or the chest pains, struggles to provide for their families, do you think that's changed in recent years? I feel like men have constantly had that. What do you think is different in the modern age of how men are approaching health versus before?
I'm not sure if it's changed in most people. Certainly there's an emphasis on this, and males are more interested in health topics, but it's still very common for males to say, my wife made me go to the doctor. That's the number one reason why any male goes to the doctor. Their wife or their mother, or the daughter or whatnot made them. And I think that this can change in the future. Part of this is how males are wired. I think perhaps part of it is even metaphysical or spiritual as well. But at the end of the day, health knowledge is at an all-time high. And fortunately, there's tools where people are able to take control of their own health, even without a doctor. So we're approaching a state where people can invest in their own health. So rather than just buying more life insurance, put those funds and resources towards giving yourself more health span.
Yeah, the push towards preventative versus, kind of waiting until you're in the emergency room seems to be a healthy trend. A trend that I see, that I saw a study as I was doing research for this, and it really surprised me. It says there was a comprehensive analysis of testosterone levels from 1999 to 2015 or 16, I believe. It's about 15 years. And it stated that there was a 25% drop in testosterone amongst men. So between 1999 to 2000, it was around, on average, 600, 605. And in 2015, it was around 450 on average. What's going on here? What do you think is causing this massive drop in testosterone just in the past decade or two?
There's many issues. Obesity and insulin resistance is one of them. Sleep apnea is another big one. Microplastics and toxins in the environment is another contributor, but actually not as big as sleep apnea and metabolic syndrome, which is basically obesity, in my opinion. Lack of activity, worse sleep in general, even outside of sleep apnea, not being outdoors as much. I think a lot of these things do contribute. But one thing to keep in mind with total testosterone levels, which is what this is being studied, is the higher your insulin, the lower your total testosterone is going to be because of a protein called SHBG. So although our total testosterone levels are much, much, much lower, we're still synthesizing almost as much as we previously did. So we're actually still making almost as much testosterone, but it's being metabolized much faster, which of course still affects people and gives them symptoms. But it's something to remember that the crisis is not necessarily just in making testosterone. It's in the stability of androgen and estrogen levels in the body.
Got it. So you would need the free testosterone as well to really determine how much someone's impacted by this, you're saying.
Or just total testosterone and SHBG. If SHBG is below about 20, then they're likely metabolizing their testosterone at too fast of a level to maintain a good, healthy, normal total testosterone. And that's why some medications like semaglutide or tirzepatide will also increase testosterone, not because you're synthesizing more, but because that binding protein metabolizes it much slower. I actually very recently posted a podcast there was a study that said tirzepatide increases testosterone more than TRT. Yes, it was a misleading study because they basically just underdosed the TRT on purpose to get that result. But the tirzepatide did take testosterone from about 200 to about 350 on average. So you can get your total testosterone much higher even without synthesizing more.
And you mentioned sleep apnea being, you think, as one of the key factors. I didn't realize how common sleep apnea is, but now that I've kind of had other guests on the show talking about it, it seems to come up more often. It was just even having a conversation with my brother who said he's sleeping, but he would wake up in the middle of the night and then feeling tired the most of the day. Is there a way to know whether you have sleep apnea or if you're just sleeping poorly? Like what's kind of the indicator there?
Yeah, there's several ways. There's a set of questions that your doctor or you could ask yourself as well. And these are, do you wake up in the night? Are you gasping? Do you have any witnessed apneic episodes, which is a witnessed episode where you stop or pause breathing during the night? Do you feel refreshed in the morning? Do you feel like you have to nap? Are you hypersomnolent? So are you more tired than usual? Is there excessive daytime sleepiness? And then if these questions are generally positive, or if a couple of them are, then you do a sleep study. And there's two big barriers to care of why not enough people have gotten a sleep study. The first is you don't have to go and get a full polysomnogram. So you don't have to go sleep somewhere else for a night. You can get a home sleep study. Somno is a very, SOMNO is a very intense home sleep study service. It's a 2-night sleep study. And just because you have an AHI, which is your apneic hypopneic index, it's basically the score of how bad your sleep apnea is. The higher it is, the worse it is. Just because that meets criteria for sleep apnea doesn't mean you need to put on a mask, which are called CPAPs and BiPAPs. There's many different treatment options, and there's a lot of things that you can do, even lifestyle things, that can improve your sleep apnea.
Yeah, and when I think about someone that has low testosterone, they would go to their doctors or their clinicians. What percentage of them do you think actually, talk about the lifestyle changes as being the biggest needle mover versus saying, oh, you know what, this is just natural, or you're normal within range, or this is just genetics? What percentage of them actually understand and can give you the right treatments, or perhaps just treating you to TRT without really knowing some of the side effects of it?
Most physicians are not adept at managing low testosterone or hormone pathologies in general. There are many good urologists, like my friend Dr. Fantas, that can look into the causes and don't just reflexively start the same cookie cutter HRT protocol for every person. But there is not necessarily one right protocol, of course. There is a right protocol for each person, and a lot of that is up to the individual, even if this is pure lifestyle intervention. The doctor should explain all of the benefits and risks of each intervention and then come to a shared decision which of those outweigh the other. Like if it's a scale, you have all of your pros and cons. The pros should certainly outweigh the cons for that specific patient.
Got it. If you had 12 to 24 weeks, let's say, to raise someone's testosterone without any drugs or TRT or anything like that, what are the three top levers you would pull first? Obviously, this is general advice, but what are the most common patterns you've seen?
Yeah. Diet, exercise, and sleep are the biggest levers. Those are more powerful than any of the other minor levers. And for diet, you want to make sure that you're getting enough calories, that you're not in a caloric deficit. It's hard to maintain optimal testosterone levels if you're, people can't be in a caloric deficit forever. Not that people can't diet from time to time, but you also want to make sure that you have adequate fat in the diet. Up to 30, there's some evidence that 30% of your calories from fat leads to better testosterone levels. Exercise, you want to have a mix of resistance training and cardiovascular training. You don't want to purely run. You want to have some cardio and some resistance training to help decrease your insulin, because exercise helps your cells uptake carbohydrates, similar to how insulin does. And because you don't have as much insulin around, the area under the curve insulin, if you will, the average insulin, you're going to have a higher binding protein for testosterone, again, called SHBG. And that's going to lead to less metabolism of testosterone, and it's going to be around for longer, leading to a higher level. And then sleep, because that's when you synthesize your testosterone. If you do those three things, it can make the biggest difference. That being said, you can't guarantee someone that it's going to double if they do those things. But in general, the worse those three things are when you get your initial level, the better results you can expect.
Yeah, I was intermittent fasting and sometimes doing 3-day fasts in my 20s without understanding any of the potential effects of it. And I did suffer a lot from having lower testosterone, but I thought this was a good thing for my health in terms of longevity. And obviously there's evidence to show that. It is the idea with fasting that oftentimes you are in a calorie deficit, meaning you're putting more stress in your body, and that increase in cortisol is lowering or inhibiting some of the free testosterone that's in my body.
It can be the case, but it's not always the case. Often when your body is more in a catabolic state, there's going to be less signaling and less synthesis for testosterone. So it's not like it's a light switch, anabolic, catabolic, off and on. It's more like a dimmer switch that's always moving. But again, it's the average amount of catabolic versus anabolic activity. That being said, there is some people have a big effect when it comes to cortisol and testosterone. The way that I explain this is it's kind of like getting into a fraternity or a sorority. Figure out what's blackballing your testosterone if it's low, and then attempt to fix that if it is fixable. So it could be prolactin, it could be cortisol, it could be estrogen. Estradiol is your main estrogen. And I'm a fan of getting good objective data and measuring those things in the labs, because if someone just feels like cortisol is inhibiting their testosterone production, then it might not be the case, and you might get a lab and their cortisol is perfectly fine.
And cortisol, I guess you just get that. Would that be like through inflammation also, like CRP, or what are the key blood markers for cortisol?
Yeah, cortisol is interesting. So it's a glucocorticoid. If people have ever taken prednisone is kind of a medication version of cortisol. Not exactly, but cortisol is made in the adrenal gland, which is a small hormonal gland, endocrine gland, just above the kidney. And it is stimulated by ACTH. So ACTH comes from your pituitary in your brain, and it actually stimulates both cortisol production and DHEA production. My friend Andrew Huberman recently did an episode on cortisol as well, and he points out that you can also have cortisol that is stimulated by hypothalamic and brain activity that is not ACTH driven. So it can be driven without a hormonal input via circadian rhythm. So you have melatonin that's released in a nocturnal circadian rhythm. Again, think of a wave in a wave pool. And then you have cortisol that's released in a diurnal circadian rhythm. But having high cortisol peaks in the morning is good, because that's what helps you wake up and feel energetic. So lower cortisol is certainly not always better. But high cortisol is associated with things like Cushing's disease. In fact, John F. Kennedy had a deficiency in cortisol, something called Addison's disease. And he received basically cortisol replacement therapy, which is you replace two different hormone activities, not to get into too much detail. But it is very related to testosterone levels. Just like testosterone has a binding globulin, cortisol has a binding globulin. But I think cortisol and adrenal fatigue, or like too low of cortisol, is too often used as an excuse for symptoms, where the symptoms are usually driven by something else.
Okay, yeah, because I never thought of anyone having a problem with low cortisol. I was like, can't you just put them in more stressful situations and their cortisol, they're going to go up? This is bro science, obviously. Yes.
Things like caffeine actually are great drivers of cortisol production. But the theory behind adrenal fatigue is that it goes from a high cortisol state, and then you burn out your adrenal gland, and then you're no longer able to make the cortisol. So I think they call it wired, but something else. There's a catchy term for it.
Interesting. Okay, so it's really from the intensive cortisol that you got from the previous years of being burnt out, and then now you're just not able. Your body's trying to balance it out because they're saying like, you had too much cortisol before. Let's calm down. I'm not going to release as much cortisol.
Yeah, there's not really a great medical evidence for that statement. What there is great medical evidence for is something called adrenopause. So people might be familiar with menopause. Andropause is just kind of a term to explain that testosterone levels tend to decrease over time as well, just not precipitously like female hormone levels do during menopause. Adrenopause does normally happen, and that is a slow decrease of all adrenal hormones, regardless of your health. So over time, adrenal hormones will certainly decrease regardless. So that is adrenopause.
Got it. Just to circle back on diet, you mentioned, you kind of highlighted 30% fat is pretty ideal. What's your kind of take on fruits and fructose in general, the healthy kind, when it comes to testosterone? I think I saw your Instagram post of like the bear. It's just pretty funny, which we'll go back to. But that was more around heart disease, right? But what's kind of your take on that? And because obviously rice and fructose, all these things, they do spike blood sugar levels.
Yeah. So fructose is, of course, a type of sugar. And the reason why it's related to bears is because bears kind of, classically love blueberries. And some bears eat a lot more blueberries than others. But blueberries are considered a high fructose fruit. Watermelons also have a pretty high level of fructose. Fructose has kind of been demonized because of its study in rats. And certainly if you feed fructose to anything, highly refined and processed fructose, like that's in sweetened beverages and whatnot, then any animal will get obese from over-consuming fructose, or any sugar for that matter, even honey, I think, if consumed in excess quantity. But fructose has some interesting hormonal tie-ins. So generally it helps increase leptin signaling, and it also makes visceral adipose slightly more active. So let's say you have world's strongest man, Thor, and he goes into a bulk phase. I think he recently bulked up from 340 to 440 pounds to do a 500 kilogram deadlift.
Damn.
Now, I would make a case that as he increases his weight by 100 pounds or 45 kilos, however much that would be, he should watch the fructose in his diet, because otherwise he's going to put on more visceral adipose. That's adipose in and around the liver and the abdominal cavity. That's particularly bad. But in some cases, for example, women that don't have enough LH and FSH, like hypothalamic amenorrhea, fructose consumption might be extremely beneficial in their case. So these are individual dietary needs. But for the average person, if they're in caloric maintenance, they're not in a huge deficit or bulk, then fructose is perfectly fine and healthy in normal quantities. My podcast co-host said if if blueberries are wrong, then maybe I just don't want to be right or something, because he loves eating blueberries every day.
Blueberries are awesome. And it has like pretty low glycemic index, right? So I'm all for that. So you mentioned 30% fats, and then, okay, so you're saying some carbs is okay. Where would you put the percentage of proteins? Would it be like 60% majority of it should be protein, and then the 10% carbs and 30% fat? Like, how would you allocate that?
Yeah. If this is breakdown by calorie percentage, then it would be much less than 60% protein. So
Right.
protein and carbs have 4 calories per gram. Ketones and alcohol have 7 calories per gram, and fat has 9 calories per gram. So fat is, on average, about twice as calorically dense as carbs. So about 30% of the calories would be from fat, but it wouldn't be 30% of the grams. It'd be much less than that from fat. Of protein, about 1 gram per pound of body weight per day. So for someone who is 220 pounds or 100 kgs like me, that's about 220 grams of protein per day, which is pretty high. Depending on how many calories you spend, that might be pretty different. For example, on a complete rest day where I'm just walking after meals and I really don't do much else, moving or exercising other than that, I'm going to consume something like 2,000 less calories than I might do after a day that I do a high rocks workout and a CrossFit workout and I walk all day, but I might actually consume the same amount of protein. So I do consume many more carbs if I'm running, a half marathon or doing a high rocks or hiking up a mountain and down, but I don't increase the protein because I know that's just going to cause me some GI distress if I try to get 400 grams or 500 grams of protein in a day.
Yeah, that makes sense. Speaking of workouts, so if you were to take the world's strongest man, who, let's say, assume he didn't do steroids. I think most of these guys do steroids, right? And you were to take someone like Cristiano Ronaldo that obviously lifts weights, but does a ton of cardio. And also the assumption with the strongest man is that he's usually working out in terms of like workout to failure, maybe like 1 or 2 reps or something like that. Which one would likely have the higher testosterone and why?
Yeah. I would say the more balanced athlete like Cristiano Ronaldo would have a higher testosterone. Strongmen, like NFL linemen, extremely large rugby players, most males over 300 pounds, even if they have a body fat percentage of 20% or 25%, which is somewhat reasonable, they have so much absolute body fat poundage. For example, they might weigh 400 pounds, but only have 100 pounds of body fat, but it's still 100 pounds of body fat. They usually have so much hyperactive signaling of insulin that, again, their SHBG is very low and their total testosterone is very low. So I would be shocked if, I think Mark Henry was a famous strongman that was supposedly lifetime natural. And regardless if he was or not, but I think he was something like 6'5", 350 pounds. He could dunk a basketball. Maybe he still can, I don't know. But I would be shocked if his testosterone was higher than the average healthy soccer player. The caveat to that is runners also tend to have very low testosterone. There's one study that looked at runners that ran almost every day and they had very low testosterone, whereas people who did half of their workouts strength training, half of their workouts running, testosterone is fine.
So it's always that balance. You can't be the world's strongest man, but you also can't be Terry Fox running marathons all day and every day. It's got to be that balance, yeah.
Not unless you get lucky. There is an interesting example. So there's several cases. My friend Derek, who has the More Plates, More Dates YouTube channel, he spoke about Olympic athletes that are female, and they actually have a high incidence of something called hyperthecosis, which is where the cell in the ovary makes testosterone more often, and they become particularly good middle distance runners. So they can run very, very often, but they don't get this testosterone deficiency. It remains high, and they develop a lot of androgen responsive muscle mass. So I believe several elite 400 meter and 800 meter runners that are female just are natural phenomenons for testosterone production. And the same is probably true of a lot of elite male runners, especially in the middle to probably not marathon distance, but distances where you want to maintain a decent testosterone level. Oddly enough, many male marathon runners and Ironman triathletes are deficient in testosterone if you check it.
Yeah. And it's, again, going back to that balance, you said let's say the world's strongest man would have that percentage of 20%. Probably it's in the mid-single digits for a marathon runner. Would you say the ideal then is somewhere in between the low teens or maybe tens?
Yeah. The ideal for the average person is between about 10 and 20% for males, and between about 16, maybe 15% for some females, and about 30%. So there's a much wider range of relatively healthy body fat percentage in females. And for premenopausal females, this does vary a lot more often. We don't have to get into details.
Yeah.
But what I do recommend people do is at least get a DEXA scan and track your a rough estimate of your body fat percentage over time. It's much better than weight.
Yeah. And considering that it's mostly males that would care about the testosterone levels, would you say, I guess, what is the relationship between the ideal testosterone and longevity for someone that cares about both? Someone that cares about, having muscle mass, sex drive, all that stuff, but also wants to live longer. Would you say that someone that does have an ideal testosterone level, body percentage fat of 10, 12% and great testosterone, is more likely to be optimizing for longevity than someone that maybe has middle, like lower to middle? Obviously, if it's too low, it's obviously a problem, but someone that on average has like a decent amount.
Fantastic question. And we do know the answer to this question, but we don't know if it's causation or correlation. So there's been kind of retrospective studies, looking at large groups of people that we have their labs. And if they have low free testosterone or actually high SHBG, which you think in general, high SHBG is good, as long as you have enough testosterone to kind of overwhelm that SHBG protein. But if people have those markers, then they do get more dementia. But it could also be because of other causes. It's kind of difficult to say. But it's still controversial on whether or not hormone replacement therapy for people that have low hormones, so females after menopause and males with low estrogen and low testosterone. I do think that the lower the estrogen of the male, I think that does lead to more risk of neurodegenerative disease and also cardiovascular disease, specifically plaque-related cardiovascular disease. TRT in males actually might increase the risk of electrical cardiac disease, but it does seem to decrease the risk of plaque-related cardiac disease.
Which would kind of give us a pretty good data, right? Because cardiovascular disease is still the number one killer of men. I don't know about women. So considering that is the case, it seems like there is a pretty high correlation. I just don't know if someone has an ideal level of testosterone, if there's downsides other than hair loss, which we'll talk about.
Yeah, there's always downsides. I like to say, in order to be adept at advising people on what to do with their hormones, because hormones do have receptors and affect every organ system in the body, positively and negatively, then you have to be well-versed in every organ system.
Yeah, it's a very complicated matter that maybe will take a couple hours to just digest and break down each of these. And then the last element you talked about was sleep. So sleep is fascinating for me because I got an Oura Ring last year and I've been really just deep diving, mostly with ChatGPT, about testosterone, sleep, and how it all kind of correlates. And my understanding is I used to go to bed at like 3, 4 a.m. It was really bad. And supposedly this was the cause of having lower energy, lower testosterone than normal. because the production of testosterone is made at a certain time, which I would love you to validate. So my understanding is that it's not just about me getting 8 hours of sleep. It's also really important for me to get those 8 hours at the appropriate time. So from a sleep schedule and circadian rhythm perspective, what is kind of that ideal sleep schedule to optimize for testosterone, and why is that?
Yeah, this is a great topic. And there's actually been some studies on night shift workers. So, of course, I've done my fair share of night shifts, delivering babies and whatnot over the years. But this does change. So a night shift worker, even if they're, working every single night, you would think that they would kind of get adapted and then start producing testosterone when it's kind of their new nighttime during the daytime. But that isn't as much the case. They produce testosterone and they have random little spikes and troughs here and there, but they do produce some when they're working, like during their daytime, but it's actually nighttime. Whereas for the average human, as you mentioned, it's very important to sleep, relatively normal hours, depending on what time zone you're in. This is usually between about 10 or 11 p.m. and 5 or 6 a.m. are particularly important hours of sleep to get optimal testosterone production. The younger you are, the more this tends to be the case. You tend to have more of a spike in the morning and more of a drop in the evening. Whereas older males tend to have less of a spike in the morning, but also less of a drop in the evening. So it is multifactorial, but the rule of thumb is that people should strive to get at least 6.5 hours of sleep. There is some interesting genetic predispositions of some people just don't need as much sleep. But for health reasons, they should at least try to get 6.5 on average.
Got it. So and just going back to the 10 to 11 p.m. portion, is that partially because it's in that kind of early phase of sleep is when we normally have deep sleep, and it's deep sleep when a lot of the testosterone production happens?
Actually, most deep sleep is usually right at the start of the night. So the easiest way to get more deep sleep is just to go to bed 1 hour earlier. But most testosterone production happens in the early morning, which is after we've had already a lot of deep sleep. Part of that's because it just takes time to ramp up. Again, think about a factory. When you turn on the assembly line, it's not going to be pushing out as much right away. So during deep sleep, it is working on synthesizing testosterone, but not much is being released into the system until the morning comes. And then a big spike does happen. So the other reason why deep sleep is important is you want to have enough time in the early evening where you're getting plenty of deep sleep, which is delta wave sleep, in order to start to have longer and longer REM cycles. Because REM is very restorative sleep. That's your rapid eye movement sleep where your body's kind of paralyzed except your eyes. You're having dreams. And if you're not sleeping a long period of time consecutively, for example, if you're like me and you have 3 children aged 5 and under, and if you happen to get woken up, which is very common, then your REM cycles are not going to be as long or as high of quality. So you're not going to feel as restored when you wake up. You're probably not going to have as many dreams. You might remember your dreams because you're woken up during REM sleep. But that's the way I think about it. Is it's the consecutive sleep hours in a row that also matter. Obviously, in some cases, like myself, in certain periods of my life, whether I'm doing a night shift at the hospital or taking care of my children, it's not possible. So I do think it's reasonable to use supplementation and in some cases even medication to improve the architecture and quality of your sleep if you're not able to get those consecutive hours purely via lifestyle interventions.
Yeah, it's and I want to just talk about supplements because you mentioned it there, because I'm curious in some ways for a lot of people if sleep is really one of the biggest factors, if taking something like tryptophan or melatonin would actually have a higher impact than some of these testosterone boosting supplements like Tongarali or ashwagandha or Fedosia agrestis, something like that. Yep. It's not even, people don't even recommend it anymore. But yeah, talk to me about that, and then some of these testosterone supplements and how much of a needle mover these actually are.
Yeah. So I kind of consider this, there's no such thing as a testosterone booster. There is such a thing as testosterone vitamin. If you're insufficient or deficient in magnesium, boron, vitamin D, zinc, other things, then that does affect your testosterone level. And it's very reasonable to supplement those in order to account for that. Again, back to the analogy about getting into a fraternity. If one thing is blackballing you, then it can hold you back. So if you have a vitamin D level of 4, which is super low, that is likely to affect your testosterone. That's why a lot of studies on vitamin D are associated with improved testosterone after you replete that. That being said, the herbal supplements, I do like to tailor to the individual patient. So for someone that has very low insulin and very low DHEA, they tend to respond better to Tongkat. Tongkat's interesting because it's also phytoandrogen and phytoprogestogen, which means it probably binds progesterone receptors and maybe even androgen receptors without even changing testosterone levels. So some people just feel different. Fedosia agrestis, there's actually several types of Fedosia. So a lot of the studies on Fedosia are not on agrestis, and there's other brands, there's other species in that genus that are very dangerous. But basically it was based off of mostly herbal medicine and tradition, which is fine. There's lots of things that are based off of like hundreds of years of herbal medicine, but it was just dosed way too high. So I usually recommend no more than 300 milligrams of Fedosia agrestis, and generally just for people who have very low LH and temporarily. Again, kind of opening up the floodgate. The pituitary sends a lot of hormones to other endocrine glands, and it does help some people in order to kind of make sure that you can endogenously produce a high level of that hormone, and then you can remove the herbal supplement and then see if it continues to produce at a high level. Ashwagandha is an interesting one too, because at very high doses, some people feel strange, almost an SSRI type effect. But most of the studies on testosterone that show an increase are at very high doses. I actually generally don't recommend a very high dose. Some people seem to get a better response to that, especially with Sensoril or KSM-66 ashwagandha if they have high cortisol. But my rule of thumb, if you don't take anything else about the herbal testosterone supplements, is they're not for everyone. Most are safe to try for a very short period of time. But what I'd recommend is actually just getting your baseline labs. People can do that at sagebio.com or ask their doctor to order the biomarkers that I posted on the website, and then tailor their testosterone optimization protocol based off of that.
Yeah. I've heard about, it's interesting about Fedosia because I used to order it. I won't mention the brand, but they just discontinued it. I was like, what? I didn't read into it too much, but I was like, I just stopped taking it. And what you're saying is just the dosage was too high. So if I decided to cut it in half and take it, it would have been fine. The compound itself is safe.
Yeah. The main side effect of Fedosia, when you look at the preclinical studies, which is the animal studies, specifically for agrestis, is it can elevate intracellular enzymes. That might be partly how it works, but it can elevate things like alkaline phosphatase, which is alk-phos, GGT, ALT, AST. So for my patients that I have on that, I just have them check those levels every 3 months. People can do that themselves too. You don't have to have a doctor's order to order labs at sagebio.com or other websites. But you definitely want to monitor your liver enzymes. Those intracellular enzymes also work in the gonads and the testicles as well. So part of it might be a sign of it working, but yeah, the doses that started to have that toxicity, if you have what's called a equivalent dose, kind of like a animal to human equivalent dose, is around 300 milligrams per day or 2,000 milligrams per week. So I tell people to limit their Fedosia consumption to no more than 2,000 per week.
Got it. Last topic on hormone optimization is kind of assuming everybody's tried all of these things, which I think is probably what you would recommend before going into hormone therapy. Talk to me about that last resort of TRT and hormone optimization there. What are what are the options available, and what are the downsides that people should be aware of?
Yeah, this is a great question. So for a lot of people, this is a bit of a false dichotomy. People are either wanting to skip straight towards this, which might not need it. I tell people, instead of asking, should I be on TRT or not? Instead ask, what things am I trying to improve? Even if it's things like athleticism, body composition, functional fitness, those are goals of high merit, and people should have those goals. They're not superficial. That's going to improve their health span and everything else, and just give a very accurate and unbiased assessment of where are things at currently compared to 20 years ago, or whatever the case may be, and have that discussion. And then see if there's things other than, because it's just a tool like any other medication or supplement, right? Is this tool the right one with the least downsides? Or maybe we can consider something else, or a short-term course of these therapies combined, and avoid having to do it. And then the other thing to keep in mind is, if people do choose to do HRT, you can get off and regain whatever hormone production you had before 99% of the time. So if someone has a total testosterone of 320 and they try TRT and then it hasn't fixed the various things that they want, they can get off and get back to 320. They just might not get back to 900 because they didn't have that before. So I would consider all those things. The natural progression is exactly what you mentioned. They should try to identify the root cause and address the root cause if possible. And I always tell people, don't punish yourself for increasing your testosterone. See how you feel as it's increased. And don't try to have as low of a testosterone as possible just to get TRT or HRT. So we're kind of taking the emotion out of it and just assessing it very analytically.
And what are the downsides that this should be? Or I think I saw like an interview or post by Aubrey Marcus talking about his TRT experience and how it led to just killing all of the potential fertility potential that he had as he's trying to have a child with his partner. Is that one of the biggest downsides, and how big of a risk is that?
Yeah. So this is a massive risk. Some people overestimate it and some people underestimate it. It will temporarily affect your fertility, but only about half of males on TRT are azoospermatic, which means like about half of males do have some sperm and some fertility on TRT. And when you come off, or when you use things that are adjuncts like HCG, FSH, etc., gonadorelin, most males do regain fertility pretty easily and pretty quickly. There is one huge caveat that people forget. You must get a semen analysis before starting TRT, because it is very possible that you have zero even before you've started. And then if you start and you don't know what it looks like before, you obviously can't have negative numbers, but it can be much, much harder than if you had started from zero and then addressed that, frozen some sperm, whatever the case may be, before you start. So people can go to, there's several websites, Yo, Home Fertility, Give Legacy, Fellows. I usually use the newest, most updated Yo Home Fertility test, which people can order. It ships to their house. It's very affordable. People can do that right away before even considering TRT. And then if it's low, obviously go to a specialist and get that addressed before starting TRT.
There was a study or research that I saw that sperm count has declined by 1% since like the 70s. And beyond TRT, just for men, how much does sperm quality actually decline with age? And I've seen this trend now of like, obviously women are freezing their eggs, but now men, because of the issues with phthalates and microplastics and all that stuff, that it's becoming more of a trend for men to freeze their sperm at an earlier age in case, they want, they want children later on. So what are your kind of thoughts with that? Is that a good idea? And how much does sperm quality actually decline with age?
Yeah, I do think it's a good idea. it depends on the person. So generally what fertility experts do is they test for things like DNA fragmentation, which is slight damage to sperm DNA over the age of 40. But there's a lot of people that are 50 or even 60, and they have almost no DNA fragmentation. And their sperm morphology and quantities and counts are fantastic. Yes, these are usually people who have had excellent diet and exercise and sleep throughout the period of their life, and they haven't been exposed to as many chemicals or pesticides or toxins or microplastics. But my rule of thumb is if you think there's a chance that you will want fertility in later age, it is affordable and easy to freeze sperm when you're younger. So freeze sperm when you're as young as possible. It's not near as important for a female that might want to have fertility in her 40s to freeze eggs very early on. That's a difficult decision because it's also much more difficult and expensive to do to freeze eggs than to freeze sperm. But I do think it's a good idea, and I do have a lot of my patients do this before kind of progressing with treatment. That being said, I personally haven't. Like I mentioned, I do have 3 children, and but it is something that I thought about and considered. But a lot of people that are most worried about it have some of the best lifestyles and lowest toxin and plastic exposure. So maybe they don't need to as much. And unfortunately, many people who aren't even thinking about this in their 20s and 30s, then when they want to start a family in their 40s, they have several decades of high levels of exposure, and it's just too late at that point. So then we talk about, different supplements and medications and antioxidants and things that can help to some degree.
Yeah, it's often the case, right? The people that are actually worried about it are the ones that probably don't need it. And well, you mentioned some of the, what are some of the places you can go to, and how much is it roughly per year for men to freeze their sperm?
Yeah. So for my patients that freeze, I always have them do it at least 2 different businesses. So for example, if they freeze them through givelegacy.com, that's one of the ones where they ship it to your house and you can ship it, and they'll try to flash freeze it. Sperm has to be flash frozen in order, especially if you want to maintain some motility. But for every year it's frozen, you do lose a little bit of motility. So it becomes harder and harder to use for IUI, which is turkey baster for those that aren't familiar with that. But you can still usually use it for IVF. But a lot of my patients will freeze via Give Legacy, and they have several plans. I think it's about $100 a year to keep frozen, and then $500 to $1,000 to freeze in the first place, depending on which plan you get. But a lot of people get the lifetime plan that's something like $5,000. Local places just vary. Coasts are higher, other countries sometimes lower. But I always have them freeze it at their local urologist REI, and then also this other place. And then generally each business they freeze it at, they'll have it frozen at 2 or 3 or even 4 different locations. That way, if there's a power interruption or, you don't want to become paranoid, but it's possible that, a fire would happen or something. So that gives them a lot of redundancy and peace of mind. And in most of those cases, even if someone starts TRT or whatnot, whenever they do choose to start a family, I have not had a case yet that had present sperm before that did not regain their sperm after. So there's
awesome.
There's a lot of other things that people can talk about. Infertility is becoming actually a pretty big issue. The last thing I'll say on that is the factor that is least often considered is age. So when you are 20 years old in your early 20s versus in your early 40s, your fertility is going to be much, much better regardless of toxin or microplastic exposure or your lifestyle. So unfortunately, most people, they in their early 20s are just not thinking about potentially freezing sperm or eggs or having a family at that point.
Yeah. Which goes to show you that society is kind of pushing the boundaries of what evolution wanted us to do, because it seems like evolution would have wanted us to have babies at its healthiest state in our early 20s.
Hundreds of years ago, the average life expectancy was in the 40s. So it was actually very common to have children when people were, 20 years old. That was like, I think, average age of first kid. I've seen a graph that talks about the average age, and it does keep going up. And there is confounders there, like hormonal contraception and contraceptives in general have become much better, which is probably still a net positive thing. But yeah, that's probably a discussion for another time.
Sure. Yeah. I wanted to go in relation to hormones, testosterone for particularly men is ED. And you've spoken about the dopamine wave pool that is happening within society. Can you talk to me a little bit about what that is and how much of do you think that is causing ED for most men versus testosterone levels?
Yeah. So for people who don't know, the way I explain the dopamine wave pool is you have a dopamine seeking behavior, whether it is adult films, whether it is, taking your sugary drink, your latte, even taking Adderall or whatnot. And after that, you have a dopamine crash. So for people who have ADHD that take Adderall or other dopaminergic meds, after it wears off, there's often kind of like a little bit of a depressed type state. And this is very important for erectile function. So you have your sympathetic, which is fight or flight, and parasympathetic activity, and they're playing tug of war at the same time. It's like one of those ladder games where the ladder's only attached at 2 points, and you have to balance your feet on both ends of the ladder and then you reach full erection when you can balance it better and better. Plenty of sympathetic, plenty of parasympathetic. But for a lot of men, they just have too much sympathetic fight or flight activity. And then, you lose erection very easily that way. And then once it happens, there's kind of a self-fulfilling prophecy because it's even more fight or flight and even more fight or flight. At the same time, you have a second balancing act between dopamine and serotonin. So a lot of medications are dopaminergic, like APO or apomorphine. And these medications are often prescribed and combined with Cialis and Viagra generics in order to improve erectile function or for sexual health optimization. And the downside of a lot of dopaminergic meds is premature ejaculation. The downside of a lot of serotonergic medications, for example, in a lot of countries, Duloxetine is prescribed for premature ejaculation. They delay things. So you want an even balance of serotonin and dopamine. So that way things do not happen too quickly or not quickly enough. And then on top of that, of course, testosterone to estrogen ratio also matters. Many people who are on high doses of estrogen blockers feel like they have zero sex drive. And my friend Derek with More Place, More Dates famously said, people that are on an anastrozole, which is a aromatase inhibitor, their penis becomes nothing but a flap of tissue with which to urinate.
Well said. So in relation to that, then, when you're talking about the impacts of dopamine pool wave, what do you think is the ideal, I don't know if there's an ideal frequency of masturbation for men to have, an optimal testosterone, let's start there, and also to minimize the harmful effects of something like ED? Or premature ejaculation. I don't know if those are the same, kind of in the same bucket or completely different.
Yeah, great question. So I guess to explain the dopamine wave pool a bit more, when you have too high of a peak, the water splashes out of the pool, and then you lose the height in the pool. To make it more complicated, your dopamine sensitivity, the depth of the pool can go up and down at the same time too. So you definitely don't want to have such a high dopamine peak that it splashes out. So that's why people that take things like ecstasy or cocaine, like other things that kind of lead to too high of a peak, after that, they're just much less sensitive to their endogenous dopaminergic signaling. But an ideal frequency depends on what the seeking behavior is, because you want to reinforce the natural cycle of your wave pool. You don't want to upset the resonance frequency, if that makes sense. So whatever the resonance frequency is, for some males, this is once a day. For some males, this is twice a week. I would say a good rule of thumb is at least 4 times a month. There's some health benefits. I don't think that there's any long-term health benefits to no FAP, if people are familiar with that.
Yeah.
And I think that's kind of out of favor anyway. That was probably big 5 or 10 years ago. But there's also no health benefits to multiple ejaculations per day. But just like when you seek after something that kind of leads to a positive feedback mechanism, ideally you want this to be seeking after something positive. So obviously in the case if you have a spouse, then a healthy sexual relationship with your partner. Generally when especially males seek after images, this leads to a dysregulation in what they like to seek after. And that is going to lead to some stormy seas. So it's not, the brain gets in a habit or mindset that is traveling in the wrong direction that makes a healthy sexuality more difficult.
Right. I've heard, speaking of NoFap, I think there was like 2 small studies done, but with like 10, 12 healthy males. And they said that testosterone did increase after like a week or so, but then it kind of ended up flatlining in the end. Is that right?
Yeah, that's correct. So, and if studied for long enough, the testosterone level is probably not going to increase over a long period of time. So I know in at least some of the studies, there is a short-term increase. A lot of athletes will avoid ejaculating for about a week before a contest, but I think the benefit of that is mostly placebo. Now, you don't want to spike your prolactin directly before something. So my rule of thumb is not at 6 or 8 hours. If you have a event like weightlifting or powerlifting or football where it helps to have a little bit of that aggro type aggression and, put that aggression into that sport, I would avoid that because prolactin does spike after ejaculation and that can make you feel blah and tired.
Right. Got it. So there is some benefit of, holding out once in a while, whether it's a day or 2 days or something like that, but it's not no FAP either. It's the balance. Yeah.
Yeah. And a lot of it just depends on how you feel, like anything else. So, if it helps you feel better, it doesn't really matter if it's placebo or nocebo.
And for someone that has, maybe facing lower testosterone, they have low libido or having issues there, is there any benefit just to like completely tapering off for how they're, ejaculating? Is it like good to have a cold start?
Yeah, outside of social reasons, it is helpful. Ejaculating is not extremely helpful for the prostate for younger males. It can depend if you have a congested, very enlarged prostate and you're also having no ejaculations for a long period of time, that can lead to different issues. But I do think that there's a lot of benefit, especially if it is someone who does not currently have a partner and they're looking for things to seek out other than that dopaminergic spike.
Got it. Yeah, that's helpful. And then in relation to what we initially talked about, which is the increase in testosterone and what it could do to hair, what is the relationship there with people fearing high testosterone and potential hair loss? What actually causes hair loss? And when do most men start to experience it?
Yeah. So hair loss is multifactorial. And if you took a biopsy of someone who is losing hair, it would look actually pretty similar to an autoimmune disease. That being said, we've tried a lot of things, and there is some types of hair loss due to autoimmune disease. We actually have relatively new medications called JAK inhibitors that are fantastic for it, but most males losing hair is androgenic alopecia. Some males tend to lose more hair because of thinning and miniaturization, which is kind of more female pattern androgenic alopecia, which might be related to low estrogen. But the primary reason is excess androgens like testosterone and DHT binding the androgen receptor. And regardless of genetics, there's all these genetic tests for hair to see why you're losing it. How sensitive is your IGF-1 receptor? What's your 5-alpha reductase activity, like a genetic polymorphism level? But at the end of the day, we have a very simple test, a testosterone and DHT and estradiol test, and we can see what's actually circulating through your system. And the management is going to be very similar. So when you treat males with anti-androgens, whether they're topical or oral, there's tons of different types. Androgenic alopecia slows and often gets better. So, and that being said, you look around at females that have female testosterone levels and they almost never get androgenic alopecia. So why don't they have if it's truly like autoimmune or insulin resistance or whatnot? And that being said, if you have an autoimmune disease or if you have insulin resistance, then hair loss can certainly be worse, but the females that have those things are not getting androgenic alopecia. So there's 3 things in a hair loss regimen that each person wants to address. Yes, TRT might make it a little bit worse, but the more androgenic the hormone, the more hair loss there is. So DHT is the most androgenic. You want some sort of anti-androgen, even if it's a topical that doesn't go systemic. Yes, topical finasteride and dutasteride both go systemic to some degree. You also want microtrauma, which is like microneedling, derma rolling, even lasers and lights is technically microtrauma. And then you want some sort of growth agonist, which is kind of like fertilizer.
Got it. And my understanding is finasteride or dutasteride is kind of the tape of the leaky bucket. So it's going to prevent more from falling out. And then the bucket of water that you're pouring in is the minoxidil or microneedling, which amplifies the effects of minoxidil. Can you kind of differentiate the I guess, the 3, I guess?
Yeah. The analogy I would make is, let's say I used to have a lawn care business. Let's say you're growing your grass in your backyard. The minoxidil or PRP or exosomes or THK copper peptide or latanoprost or bitanoprost, that's the fertilizer. The anti-androgen is the pesticide agent. So there's grubs and they're eating your grass. They're eating the roots. That prevents the grubs from eating your roots. The microtrauma, whether it's microneedling or derma rolling or whatever else, actually technically massage, which you would have to do for like hours a day to help. But that's also technically microtrauma. That's helping the collagen bundles. So that's more like core aeration. So you're like aerating out the roots. You're helping the health of the roots, but you're not addressing the grubs. So you got to address the grubs with your anti-grub, like pyrolutamide or spironolactone or dutasteride or finasteride. And then you also, to have optimal quality hair, the grass in this analogy, pick a microtrauma and pick a growth agonist. My favorites are, as long as you're not trying to conceive a child, dutasteride, microneedling, and minoxidil. And my favorite, if you are, is no androgen during that time. But if you don't want a systemic androgen, I do like pyrolutamide and topical spironolactone.
Is there, because there's this whole thing, and Derek talks about this a lot, which is the whole post-finasteride syndrome, which happens. And this kind of goes into the topic of topical versus oral. What is post-finasteride syndrome for people that don't know, that I should? And what's kind of what do studies show around the effects of topical versus oral in terms of the systemic risk, but also the effectiveness of taking each?
Post-finasteride syndrome is a constellation of neurologic and sexual side effects that happen even after you stop the finasteride medication. Finasteride does have kind of some unique side effects. I've taken it myself, and maybe I had a little bit more OCD type tendencies. I'm not OCD, but sometimes maybe I would have slightly more of those type of thoughts when I was on finasteride compared to now when I'm on dutasteride. But
why is that though? Actually, I
There's a lot of theories.
It reduces the DHT, yeah.
It probably doesn't have to do that much with DHT. It has to do with where in the organ systems and the brains it's working. Without going into too much detail, I have done hours of podcast on this. Finasteride most strongly inhibits type 2 5-alpha reductase and a little bit of type 1, whereas dutasteride more evenly inhibits type 3, type 2, and type 1. So those different types are in different ratios in different organ systems. For example, finasteride works much stronger relatively in pubic skin, like penile and scrotal skin, whereas dutasteride works relatively much stronger in non-pubic skin, like the skin of the face and the back and even the scalp, actually, whereas they both work very heavily in the hair follicle, which is where there's several types of the enzyme in it. That being said, there's a lot of theories of why it tends to happen, but the uneven inhibition of those enzymes is one of them. The other one is, just like testosterone can convert to DHT, progesterone can convert to DHP. And actually, allopregnanolone and isoallopregnanolone and these other types of progesterone, again, not trying to talk over people's heads, there's a synthetic version of it that we actually give for postpartum depression. And there's a lymphatically absorbed capsule that's being studied that would be indicated for many types of depression, probably PFS-related depression too. But basically, there's a lot of other hormones that these medications affect, and they affect it in unique ways. So definitely something that you should have a conversation with a doctor to take, but I'm obviously not against it because I've taken both myself.
So do you think most people should just start with topical in case they're concerned about some of these issues that might come from taking finasteride, or what was the other one? Dutasteride?
Yeah. So starting with topical KX826, which is pyrolutamide, or even maybe Cosmo RNA, which is a different topical, or compounded topical spironolactone is reasonable. Topical finasteride is absorbed, but slowly. So it's not as common for people to notice side effects. But yeah, almost half of the topical finasteride that you apply can be absorbed into the body. And about 1 or 2% of topical dutasteride is absorbed, unless there's a liposomal, like special absorbed form of dutasteride that had a tiny study that it wasn't absorbed a ton, but I've seen a lot of people on it and it's absorbed a ton if it's the 2% topical dutasteride. But there's other things like corticosteroids that make you more likely to absorb these hormones. But yeah, my rule of thumb is if you're taking topical finasteride or dutasteride, assume it's being absorbed unless you can prove via labs that it is not. And if you want to start with something that's not going to have systemic side effects, start with something like the KX826, or just avoid androgens and hope that the microtrauma and growth agonism is helpful. I do have patients that microneedle themselves and use exosomes and get PRP and do as much as they can just because they're wanting to avoid all anti-androgens.
Yeah. And some of the probably for most people, the most common effect that they see if they haven't studied enough is that they actually start to shed more in the first 2-3 months or so. So what is the right amount of time for someone to actually wait to decide, hey, this is working or this is not working? Because some people give up too early.
For an anti-androgen, 6 to 12 months. More like 12 months to see fully how it's working. For a growth agonist, about 3 to 6 months. With minoxidil, people should notice for sure between 3 and 6. Same thing for PRP if they're getting a series of PRP treatments. And I'm not against PRP or PRF. We do things like that here at my aesthetics clinic. But most people, they don't wait long enough to notice a result. And if someone has very unhealthy hair, like you mentioned, almost anything that will work well will start off with a shed of the unhealthy hairs so that they can come back, basically reincarnate earlier in the hair cycle. You want to save that stem cell. As long as the stem cell hasn't left the area in the scalp, you can recover that hair. That's why I call my little dutasteride hairs whenever I'm not on my fertility protocol. my unhealthy dutasteride hairs start to come back and they look kind of weird when they're starting, like right now. But
like baby hairs.
Yeah, but those are hairs that eventually would have otherwise been lost.
Right. And this is why it's so important for men and women to start as early as possible, because once that hair follicle is gone, it's not something you can retrieve, even with, the best topical or oral treatments that exist right now.
Yeah, exactly. A little bit of treatment very consistently over a long period of time is going to give you better results than, doing 1 year hardcore everything you can and then taking 9 years off.
Yeah. Have you heard of this new treatment that came out? I'm sure you have, in UCLA, PP405. I just read the headlines, but I was so excited to just ask you about this miracle thing that came out. Is this all hype, or is there legitimacy from the study that you've researched?
It's very likely all hype.
Fuck.
I'm hopeful as well. I've seen, UCLA has actually had similarly hyped hair loss products before. It could work well, but I don't think that it is definitive enough to say. For whatever reason, this one is just blowing up everywhere on the podcast and whatnot. There's a whole bunch of other kind of equally promising hair loss meds in different pipelines. This just happens to be the one that blew up because it got some UCLA funding. Now, it is possible that it does work quite well, but I would actually be surprised if it's, the silver bullet for androgenic alopecia without having to address the androgen receptor.
Yeah, it was everywhere. So I just wanted to ask because it seems like people are posting it. I had to validate that. So speaking of hype or scam, or rather valid or scam, I want to legit or scam. Let's say that there's a few things I wanted to kind of go through with you. We can kind of rapid fire these just to see what your thoughts are. Methylene blue.
Yeah, methylene blue.
Legit or scam?
It can be legit. Not for improving your cardiovascular exercise. I don't think it's like a mitochondrial game changer, but I do use it quite often. Most often, weaning people off SSRIs, it can be very helpful. So legit.
Hydrogen water, the Gary Brecka lie.
Yeah. So I actually don't know for this one. So I am very open-minded, but I'm also very skeptical. I'm actually currently trying hydrogen water myself to see if I seem to notice a benefit.
Are you measuring something, or is this just a feeling you're going off of?
Measuring my 5K time. So I'm going to
marathon wise, you're saying
like a 5 kilometer run.
Got it. Okay.
So yeah, I'm not measuring like cognitive health or other purported health benefits. I think it's a scam for like cardiovascular health or whatever the other systemic benefits. But mechanistically, I could see how possibly it would help with aerobic fitness, maybe. I'm pretty skeptical, so it's probably going to be a scam.
Yeah, I'd love to know. I'll keep a lookout on the follow-up posts. We started this with the bear post that you have on Instagram, which I think talks about the carnivore diet and the effects of LDL and fructose and all that stuff. So why don't bears get heart disease? And is carnivore diet a scam, or is it legit?
Yeah. Unfortunately, in general, it is a scam. I do think that people should consume fiber. That being said, there is some utility using it for a very short period of time, simply as a elimination diet.
Got it. And just to kind of peer into that, why is it a scam? Is it because there's downsides of it that people don't talk about, or is the hype just not what people are saying?
Yeah, if you look at the most recent keto CTA trial, most people that are on ketogenic diets and a pure carnivore diet, unless you consider honey carnivore, that's not actually carnivore, but if someone's on a ketogenic carnivore diet, it is very likely that they're consuming immense amounts of saturated fat, and they probably have significant dyslipidemia, which I do think for many people, especially people that go into it obese and with metabolic syndrome, a lot of people do the carnivore diet because they want to lose body fat because they're obese. I think that it puts them at very high risk of fast plaque buildup in the coronary arteries of the heart. So I think of the 100 people that were studied, only 4 of them didn't have a huge progression of coronary plaque in 1 year. Now, those weren't carnivore dieters, those were ketogenic dieters. But The benefit to it is you eliminate so many foods from the diet that you could be reacting to that you can slowly add them back in after doing, 30 days of carnivore diet. I think that's very reasonable, kind of the same reason people do a Whole30 diet.
Got it. So it's more of the benefit of eliminating rather than the fact that just eating red meat is this amazing thing. In relation to that, I'm sure you follow Paul Saladino, who pretty much is an advocate of, he used to be an advocate of the carnivore diet, and then now he's adding honey, fruits, and all that stuff. But his biggest claim is that vegetables are toxic. And it's because of the high defense mechanism, chemicals, all that stuff. Legit or a scam?
Yeah, so this is largely a scam. Vegetables do have a lot of quote unquote anti-nutrients, but some of the benefits of anti-nutrients is they bind toxins in our gut. So it's actually a great defense mechanism. For example, if you're consuming something with mercury in it, like, a swordfish, let's say. Swordfish actually has a ton of mercury, and you eat some spinach, you're worried about the oxalate anti-nutrient in the spinach, right? Actually, not so much, because even though that is kind of an anti-nutrient, it's also synthesized by good gut bacteria called Oxalobacter formagenes. And it's also going to help bind up that mercury so that you just stool it out rather than absorb it. So a lot of the anti-nutrients in vegetables have very specific purposes for binding various toxins and heavy metals in our gut.
Got it. And most of the downsides can be removed if you steam it, boil it, cook it in some ways to reduce the lectins or the oxalates, right?
Yeah, correct. It's kind of one of the catch-22s of functional medicine, I guess, is a lot of people will tell you to avoid all of these anti-nutrients in your diet, and then they put you on a supplement regimen that has a ton of toxin binders, like bentonite clay, and they'll start people on activated charcoal, and those are extreme anti-nutrients. So there's some cognitive dissonance there. And I'm, for the right patient and the right time period, I'm not against those things. It's just you have to understand what is the potential benefit and downside. You can find any food and say this food is bad because of this, and that's just that is a small world view, small brain view, really, because you're not analytically thinking about the opportunity cost. Humans have to eat something. So don't just concentrate on the bad. Don't just concentrate on the good. Think about both.
Got it. And last one for you, fluoride, particularly in our waters and using non-fluoride toothpaste, which also Paul Saladino and also Robert F. Kennedy talks about in terms of removing fluoride in our waters.
Yeah, this is legit. My brother is actually a dentist, and he kind of explains it this way. So fluoride can be beneficial for preventing cavities, but you definitely do not need it in the water and in toothpaste and doing fluoride treatments at your dentist. If there's someone who is particularly high risk of cavities, then they should be able to talk to their dentist or doctor about intermittent fluoride treatments in order to help decrease that from happening. Fluoride actually binds hydroxyapatite, kind of like calcium or strontium, like some people that supplement strontium, and it causes something called fluorohydroxyapatite in the enamel in our teeth. So I don't think that fluoride is necessary in the water supply. And there is neurologic downsides, and you can also get fluorohydroxyapatite in your bones. That being said, if your vitamin D status is excellent, if your calcium status is excellent, you're less likely to have fluoride cause something called skeletal fluorosis, which is where it's full of a lot of fluorohydroxyapatite. And I'm sorry if this is kind of over people's heads, but this is like a very trendy topic right now. But yeah, in general, people in developed countries are exposed, unfortunately, to way too much fluoride.
People in developed nations, you're saying?
Mm-hmm.
Right,
yeah.
right.
Yeah, so
got it.
People in countries that are like developing countries and sanitation might not be as good. There's certainly dental benefits to fluoride as well. But many dentists, including my brother, don't use a toothpaste with fluoride in it. So in fact, people might not even need toothpaste at all as long as they're mechanically debriding the residue on their teeth.
Wow, that's a bold statement to say that we may not need toothpaste. Yeah, I think Pulse Lady uses like baking soda or something like that. But that's probably for another episode here. Kyle, final question for you is what are some breakthroughs that you see in hormone, metabolic medicine, treatments, anything around longevity, health and wellness that you're excited about that maybe people aren't talking about yet, at least in the mainstream?
Yeah, there's three big ones. So one thing that is actually pretty big in conventional medicine, but not huge in the mainstream, is there is starting to be FDA-approved stem cell treatments for specific things. Like vitiligo was one from last month, I believe. So vitiligo is this actually pretty debilitating skin disease where there's a lack of pigment. It's particularly pronounced in people with darker skin phenotypes. And stem cell treatments are working quite well for that. So I'm very excited for things like basically wound care, anything that's a wound. And hopefully that extends more inside the body. The second thing is myostatin inhibitors or actinogen to light chain. There's basically these different drugs. They're usually IV infusions, but at least 3 different companies are studying them in phase 2 and even early phase 3 clinical trials. And they're going to increase muscle mass and decrease body fat. So people are going to be extremely excited about it just because it does that. But there's really exciting data coming from all of them. I think Genentech has a couple, Regeneron, maybe, or is it Regeneron? I know Lilly has one called bimagrumab, but this is kind of going to be the next big thing after GLP-1s, especially if they figure out how to get them in an auto-injector instead of IV infusions at an infusion clinic. And then the last one is exosomes. So exosomes come from stem cells. And I think that, people previously thought that stem cell treatments can be used for everything. I mentioned some things that it's helpful for, but I've been pretty underwhelmed with uses for, like musculoskeletal ailments. I think we will be able to pick certain stem cells and get exosomes from those and be able to treat a lot of things regeneratively that we previously weren't. It's just going to take time to study that.
Awesome. You got me fired up about the future. Great way to end on a positive note instead of ED or hair loss. So
For sure.
This is great, Kyle. Appreciate your time. Where can people find out more about you and learn more about the work that you're doing?
Yeah, my main hub is Instagram, Kyle Gillett MD. I do have the Gillett Health podcast on all platforms, including YouTube, which we're trying to promote. So thank you.
Cool.
And yeah, then Sage Bio is where I post all my labs. I have my 2 different AI robots that people can use if they go to sagebio.com. I appreciate it.
Awesome. Yeah, we'll link all those down below. Appreciate you, Kyle. And thanks, guys, for tuning in.